Good morning, everyone. Thanks so much for joining us today at our COVID-19 community of practice for Ontario family doctors. I'm Dr. Tara Kieran. I'm a family doctor at the St. Michael's Hospital Academic Family Health Team and also the Vice Chair for the Department of Family and Community Medicine at the University of Toronto in Quality and Innovation. I'm really pleased to co-host these series of community of practice together with the Ontario College of Family Physicians. And I'm going to turn it over right now to Jennifer Young, who's the president of the OCFP.
Hello, everybody, and thank you for joining us this Friday morning. It's the last one of June. Hard to believe that we are in June after all of this. This is about sharing experiences, about changing the way we've worked over the last 4 months. And today we talk about supporting patients experiencing social challenges. I'm really excited about the group of people who've joined us this morning to share their stories. So, they will introduce themselves as we come along. I'd like to go to the next slide, which is our land acknowledgement. And we acknowledge that the land on which we're hosting this meeting is the traditional territory of many nations. We acknowledge that Ontario is home to many diverse First Nations, Inuit, and Métis people, and that each of you are joining us from one of those many traditional and treaty territories. We are grateful to be able to come together in this way at this time.
So I always find that the land acknowledgement is a wonderful time to reflect on injustices done to Indigenous people here in Canada in the past and continue to be done in the present. I personally have been reflecting quite a bit about the unfortunately large number of Indigenous people who are homeless in Canada. I wanted to draw attention to this CMAJ article that was published earlier this year that talks about how Indigenous people are 8 times more likely to be homeless than non-Indigenous people, and really puts forward a framework for how we can support people who are Indigenous and homeless. Partly, I've been thinking about this issue because I've been reading this great book. So if you haven't read this book already, I highly recommend it. From the Ashes by Jesse Thistle, who's the first author actually on this commentary, which is actually amazing to me if you read the book and hear his life story. Next slide. I am delighted to welcome you today, though, to our community of practice, and I think it's where we are hoping today to talk more about issues like homelessness and other social challenges that our patients face and what we can do about it. Just a reminder, and Mina's put this in the chat, that all previous webinars and recordings and the resource lists from them can be found on our website. I wanted to acknowledge our planning committee, the wonderful work they do. We at the planning committee choose the topics and the speakers. We're really delighted to have us join today with 4 new panelists. 2 of them are family doctors and 2 actually are patient partners. So this is the first time that we have patient partners joining us, which is fantastic. Next slide. We also have our guest speakers, Jennifer Young and David Kaplan, as usual. Next slide. So without further ado, I'm going to get our panelists themselves to introduce themselves, state their name, where they work, and speak to their disclosures. So Rithika, I'll start with you.
Sure. So my name is Rithika Goel. I'm a family doctor. I work at St. Mike's Family Health Team as well as Inner City Health Associates doing shelter-based work, and I have nothing to disclose.
Dawn Marie, welcome. You're just on mute, Dawn Marie.
Good morning. Sorry. Dawn Marie Harriet. I work for a nonprofit organization and coordinate a speakers bureau, and I'm here as a patient partner.
Johnny Grech.
Morning, I'm Johnny Grech. I'm a family physician and so-called street doctor in Kenora. I have no financial disclosures.
Will Lacey.
Good morning, I'm Will Lacey. I'm a patient partner, a patient of Dr. Rex, and I have nothing to disclose.
Next slide. I'm Tara Kieran, and I am a researcher, have some grants as well as salary support that I get from a number of institutions, all of which are nonprofit. The one exception is Gilead Sciences Incorporated, where I did get a grant to support some work to cure Hep C in primary care. David?
I'm David Kaplan. I'm a family doctor in North York, and I am the Chief of Clinical Quality at the Quality Branch at Ontario Health, a new provincial super agency, and I received an honoraria from the Ontario College. Good morning, everyone.
And I'm Jennifer Young, a family doctor in Collingwood, Ontario. I'm the president of the Ontario College of Family Physicians and have no relationships with financial sponsors, though I do get an honoraria from the OCFP.
So we're very excited to have all of you join us from across Ontario, many in the GTA, but also some people from further away. Next slide. So just a reminder in terms of how you can participate, we have in Zoom webinar a Q&A function. So we encourage you to use the Q&A to actually put in your questions, and panelists will either choose to answer those questions live, or they may just answer them by typing, and then the answered questions appear in the answered list. So if you want to check those out during the chat, you can as well. There's also a chat function where you're welcome to share what you, the knowledge you have and some answers you may have to the questions that are being discussed. So we always appreciate people networking through the chat and providing resources, and we do our best at the end of the session to collate all of these together. I'm going to turn it over though now for, to our panelists to get us started today. And I'm going to start with Dr. Ritika Goel. Ritika, I know you've thought really deeply about issues related to family medicine and social accountability for a long time. What are some of the types of people disproportionately affected by COVID-19, the condition, but also the socioeconomic consequences of the lockdown and our response? And tell us a little bit about how you and your practice have worked to address these.
Thanks, Chara, and thanks everybody for this opportunity. It's really great to see us coming together as a community of family physicians during this challenging time. So I, as all of you, was working in primary care when COVID-19 hit, and what became really sort of apparent to me very early on is that this pandemic was going to have a disproportionate impact on certain communities, but even more so that our response in primary care was so essential, given that the response of shutting down a lot of our in-person services and moving to a more virtual care model is one that also disproportionately can marginalize certain groups. So, what I did some thinking around is, who are the folks that may not be well served by moving sort of rapidly towards a virtual care model, and how can we make sure that we're doing our best to try to simultaneously take a public health approach, allow people to physical distance while also maintaining a low barrier approach so that we don't have a large amount of collateral damage for marginalized communities. So thinking through who that would impact, certainly anybody that you can think of who really benefits from a drop-in model of care. I'm sure we all have people in our practice who have difficulty making appointments and really do much better when they're able to kind of come in and have their needs met. As well, I thought a lot about my patients for whom relationship-based care is really important. So particularly people where I've known them for many, many years. We have a relationship. They need a trauma-informed approach, but to some extent, even more than that, they need somebody that they know and trust. And so what does it mean when we're shifting our clinics to sometimes mean that we're covering for each other much more? We may be seeing each other's patients in a way that our patients are less familiar with, and who does that disproportionately impact? As well, particularly, I was really concerned about my patients who don't have a phone or who don't have a reliable phone number. And very early on, I started to see, as we moved to virtual care and a phone-based clinic model, that there were certain patients that I could just never reach. And even if they had had, a call from the clinic saying there's a call coming around this time, just given sort of the chaos of their lives, they might miss my call when I called, and then that would end up being a no-show. And we had a bit of a rhythm. Every time they would come and see me, we would book a follow-up appointment, but now this pattern was broken. And so this no-show would mean that we're now relying on that individual to navigate the system again to get access to a care appointment. So it's particularly concerned about those folks. And I'm sure all of you have seen that our patients with severe mental illness and people who are using drugs have really been disproportionately impacted. In Toronto, we have a number of services that support people who use drugs through either overdose prevention sites, supervised consumption sites. Some of those have had to close down. We've also heard that in the community, due to COVID, a lot of folks that were responding to overdoses were sort of more reluctant to respond in the way they would. In the case of overdose, rescue breathing is a really, really important piece. And of course, during COVID, rescue breathing is not something that's feasible in the same way. So we've actually had a huge spike in the number of overdoses, likely as a combination of these factors. But the group that I've really been focusing a lot of my work on, wearing other hats, is around people experiencing homelessness. So as you can imagine, for people experiencing homelessness, it was very difficult to physically distance in any way, given that they live in congregate settings, so very high risk of transmission. We also know that at baseline, this population has a very high morbidity, mortality. The life expectancy is in the 40s or 50s, very different from the rest of the Canadian population. So they face barriers to distancing. They also face barriers to hygiene, as most of the drop-in centers closed down. You know, there was a moment where I realized I went into Tim Hortons to get my coffee, and I realized that the washrooms were closed. And so for people experiencing homelessness that have to leave the shelter during the day, they really had nowhere to go to access hand washing stations or to access washrooms for the day. And then finally, there were barriers even to screening and testing. As we rapidly rolled out, our hospitals got COVID assessment centers going. But for people who've had trauma in hospitals or have had difficulty relating to institutions in the healthcare system, asking them to go to a hospital to access a COVID test was posing a lot of challenges. And so thankfully, we've had some response. You know, we've ended up setting up mobile outreach to the shelter system. We've ended up having some socially distanced hotels that the city has put in place, but it hasn't been anywhere near enough. There's about 8,000 people in the shelter system, and only about 1,000 were able to be moved to socially distanced hotels. But in terms of primary care, some of the things that we talked a lot about at St. Mike's Family Health Team, we put together a working group that was responding, particularly looking at COVID with a structural determinants of health lens. And so we put together some simple ways that we could try to mitigate this. So one was that we tried to make our messaging really, really clear. One of the challenges, of course, is that things changed over and over. And so we tried to make messaging clear to say, we are in fact here for you. As we know, people who've had difficult experiences in the healthcare system, if they feel they're seeing a closed door in any way, they're less likely to engage in care. So we wanted to ensure that we sent the message, we are here for you. However, if it's possible for you to call ahead, if it's possible for you to pre-book, that's preferred. We also ensured that our screeners at the door were aware that we are allowing drop-in in-person access for people who are marginalized, and we tried to work with them to ensure that they could try to assess that when someone is coming to the door. We talked about having clear signage in multiple languages and trying to keep existing programs that we knew were really important for the community. So we have an addictions medicine drop-in program. We tried to keep that at the same time. And then sort of the biggest effort, which one of my colleagues led, was around setting up something called the wellness checks. And so our large family practice, kind of all of the primary care providers thought through who were the people that they were really concerned were going to fall through the cracks. And we tried to put together a list. And some of the providers who were not able to do their regular work because of COVID were kind of redeployed to create this wellness checks team. And we had them proactively reaching out to our patients to check on them to see how they were doing. And we also tried to include some social health screening into that. So we tried to include things like letting people know that there's a benefit through Ontario Disability Support Program that they could access due to COVID, or letting them know that they could access CERB if they had lost their job, for example. So those were some of the tips that we put out. We also tried to have really good regular communication with our patients and include things that were really relevant for folks who are socially marginalized, recognizing that sometimes our patients may not have phones, but they actually might have email. And we also tried to send similar messaging to our actual colleagues to just ensure that they were constantly thinking about this, that in our flurry and our own panic and anxiety around this pandemic, that we didn't forget those who would be disproportionately impacted. And I'll share with you later some of the tools that we used and resources we developed to think through that more.
Thank you, Ritika, for that. I'm really lucky to work in the same practice as Ritika and have myself and my patients benefit from some of that organizational work, even some of the practical things that they've done in terms of try to amass a bunch of donated phones for people who don't have phones. I know a couple of my own patients have benefited from that initiative, so really appreciated it. So if you have questions for Ritika and what she's saying, if you could just type them into the chat. Ritika, I'm wondering actually, maybe this would be a good time to just take a look at some of the social care guidance that you and your colleagues have developed. I know people out there are really interested in some practical tools because sometimes dealing with social challenges feels overwhelming and out of our control. And so Brian, I wonder if you could put up that slide on the social guidance. Brian, are you able to?
Thanks, Tara. So just to orient people to this, so this is a double-sided tool. So this is something that we worked on through the Department of Family and Community Medicine. And very early on, a number of us that are practicing family physicians came together and we said that one, we were noticing that our more marginalized patients were disproportionately at risk, but also that there were some really high yield information questions that we could ask and some information we could gather, recognizing of course that you won't be able to ask every single patient all of these questions in every encounter. That would be completely, overwhelming and unsustainable, but that we were really thinking that there were some high yield pieces that if we had them in mind, we actually may be able to intervene in really meaningful ways. So some of the things that we came up with, these 5 questions to consider with your patients, were thinking about whether this patient or their household would find it hard to pay for basic expenses in the next 4 weeks, given how many people lost their jobs particularly. Then thinking about whether there was a risk that the household won't have food or be able to pay for food in the next 4 weeks. Again, using that opportunity to refer people to food banks. We were lucky in our clinic to have a bit of a budget to even be able to send people some grocery cards, for example. Thinking about whether people are currently homeless or at risk of losing their housing. So referring them to legal clinics to support eviction prevention, for example, or referring them to services that were supporting people find access to housing. Asking people if they're alone and if they don't have family or friends that could help during the time. So in Toronto, we've had incredible kind of response from the community and have had a number of organizations come together to provide social isolation support, especially for seniors who might not be able to access their groceries or their medications. And then finally asking if there were any concerns about their own or their children's physical safety. And this is based on some evidence that we've seen that the risk of intimate partner violence and violence against children has particularly likely increased during this time where people are at home a lot. And if you scroll up, those are sort of the high yield kind of areas. And then if you scroll up, so in the middle there, the resources, it says the Upstream Lab Social Resource Connector. And that actually is a much more expanded version of this, where the resources are at the back end. You can actually plug in the answers to these questions and get a robust list of resources through the CEP social care guidance. Those are 2 ways to access. And then the framework and approach for us was really important. Because as much as we recognize that these are really big things, obviously these are important at all times, but asking these questions, one of the things that can be challenging for us as family docs is how do we actually approach this information? So there's some tips there around thinking about having a crisis management approach, using motivational interviewing skills, having an anti-oppression and anti-racism based approach, strength-based problem solving, and engaging in trauma-informed care. And then I won't go through it in detail, but if you go to the second page, it actually has that very, very high yield list of resources. And this is sort of my go-to. So for anybody on ODSP or OW, I told them about this benefit, and there's a number of patients who I was able to inform that were able to get connected with, an extra $100 a month is huge when you're on social assistance, or the CERB. There's also the Prosper Canada tool, which allows you to navigate financial relief. And then there's a few others. So if you scroll up a little bit, there's an extra child for benefit for folks with children. And then just some of the things that we would often refer people to. So community legal clinics, a great website called Steps to Justice, which is client-facing, patient-facing around legal information, mental health supports through Connects Ontario. And if you scroll up, some safety supports as well that we found helpful to connect people. So just a simple double-sided tool that people can use.
Thanks so much, Ritika. There are a couple of questions for you in the chat. Just one, in the Q&A. One I'll ask from Lee Donahue was, practically, how do you annotate and track the social care responses in your EMR? And do you have any idea of what % of your patients screen positive on any of the questions?
Yeah, that's a great question. So currently we don't have the tool embedded in our EMR. So it is something that is paper-based or electronic, as in you can access it on the web, but it is a PDF. The other piece though, that is connected and has really been developed through the Upstream Lab is that web-based tool. And I think they are looking at doing a bit more of an evaluation for folks who do use that tool and what the responses are there. This is all sort of relatively new. It was launched a few weeks ago. But I would say in my kind of informal experience, a lot of these questions, I may know who my patients are that are a little bit more transient. So it was really helpful for me, really just as a reminder of what are those key pieces that we may want to consider asking people, and especially around the benefits. So just thinking about who might be eligible for a particular extra benefit right now that's COVID related that they didn't otherwise know about.
So there's some more questions for you in the Q&A, Ritika, but I'm going to just pick one more for us to discuss right now, and then we'll get to the others later as well. So Bilal Ladak is actually from the UK, where he works in a practice of 5 doctors with 9,000 patients, and he was wondering, how are you able to implement checking in and wellness checks while also providing primary care services? Not sure how we could implement something similar with the 9,000 patients in their 5-doctor practice.
Yeah, that's a great question. And so as I mentioned earlier, the key piece there was really using staff that have been, essentially they were redeployed to do that work. So of course, that's something that's, quite luxurious if you're working in a group practice, not something that solo docs could obviously do. But we do have a number of staff who do really kind of hands-on care. So chiropody would be an example, physiotherapy, et cetera. So we used redeployed staff to do that work.
Thanks, Ritika. So there are a couple, Ritika, maybe you could go over to the Q&A when you have a moment, and you could even type in some of the answers and we can get to some of them live as well. But right now I wanted to turn it over to our next panelist, Dawn Marie. Dawn Marie, I know you're speaking from a different lens. The last few weeks I know have been particularly difficult and highlighted the persistence of systemic racism, both in the US, but also here in Canada. And I know you were interested in sharing your own journey as a Black woman with us, and how it's been like during this time. And I know you've also been a support to others, and look forward to hearing more about how you've supported yourself and supported others during this difficult time.
Thank you. Yes, it has been very challenging. COVID alone has been challenging for myself and the people I support. Living alone is very isolating, and not being able to connect with people, but definitely also, just even the challenge of wearing a mask is very different for people who have experienced domestic violence or may have some very uncomfortable situations wearing a mask, and just supporting people through that has been challenging, and the work that they do. Also, having to work from a distance, working from home is a very new concept and very challenging. But yeah, what's been happening across the world, and it around racism, anti-Black racism, and I'm very happy to hear that Toronto has declared that anti-Black racism is a health crisis now, because there are many, many ways that racism affects people across the sector. So racism is a social determinant of health in the same way that income, poverty, housing, and employment are. And I can't tell you the amount of, we call them microaggressions now. I do want to say that it's racism in a different term, in a nicer term. But I can't tell you the amount of microaggressions that I've faced in the last 2 years alone, and especially around housing, searching for housing. And we know how housing is so important to our health, our mental health, our being able to move forward. I started my journey talking about domestic violence, poverty, homelessness, mental health and addictions, medical care, and many, many other systems. But they're all so interconnected. And one of the things that I often, every day, think about is the color of my skin. And that in itself shows you the mental work that's happening, right? Sorry. In terms of what is the stresses that I'm facing, that the fact that I have to think about the color of my skin when I go to look for housing. And I have been working at a steady job for the last 12 years, but I've had issues within my housing from time to time. And I would say about 2 years ago, I was in a shelter. And I was in a shelter because I was moving from a different location. I was relocating from Richmond Hill and coming into Toronto, not realizing how high the housing market was and what the documentation that was needed now for just, you know, a basement apartment or whatnot. But just my anxiety would go through the roof looking for housing, to the point where I would have to take someone to come with me. And when in the shelter, a housing worker, I was trying to explain to her my anxiety, what I was going through when I was looking for housing. And she turned around and asked me if I was on medication for my anxiety. And I looked at her, and through my head, I was just thinking, so I should be taking medication for something that's been happening to me systemically. Needless to say, it was very difficult working with her again. And so I took my own chances. And it's just amazing how do I explain this? It's not amazing. It's challenging, because when we have these experiences, when we see these images on TV that we've seen, when we have these experiences of people being killed, or people being discriminated against, or people being abused due to the color of their skin, it's very hard to heal when it's not acknowledged. And I think the issue, it's very difficult to find support in the community. I'm not going to say there's not any Black doctors or psychiatrists or therapists. It's very difficult to find them. It's very difficult to find organizations. I do have a slide with resources that are a few just in Toronto, but not every resource suits everybody. It's very difficult to find supports in these times, and you have to turn to friends, family, and colleagues, some of whom are going through the same experiences that you are, and some that may not even understand the experience. So either you're re-hurting, or you may be getting some support, but not necessarily the support that you need mentally and physically. We know poverty is, we should treat poverty as a medical issue, because it brings so much illnesses with it. So does anti-Black racism. So I'm very happy that Toronto declared it an issue. Now,
Marie, I
sorry?
know that you had some resources that you wanted to share with folks, and I wonder, Brian, are you able to bring up the slide, mental health and addiction services for the Black community?
Yes. So Across Boundaries is an organization that's been in place for 25 years. They deal with people with mental health in racialized communities. The Caribbean and Canadian Social Services strengthening Black communities through psychosocial services. We have Rights for Black and African and Canadian youth, and there's CAMH for substance use. There are some other community health centers like Regent Park and Rexdale, who provide a number of services in the community around. There's also Women's College, Women's Health and Women's Hands that provide services for women. But these services are very helpful, but we also need much more. And I think we need to, I was looking across the GTA, trying to look further, and I was trying to also look across Canada. Very challenging. A lot of the services are much higher up, and not providing services for people on the ground, but more funding and things like that. And so I think we need to do more data collection around demographics and what is it that the Black community really needs to make an impact on health. And we need more mental health services. We need to provide more education and get more funding to create more services to support people in the community.
Thank you, Dawn Marie, for drawing our attention to the work that we need to do. Definitely, I know we're sharing some resources right now that are a bit Toronto-based, and that's, as Dawn Marie said, we did try to find some others, and it was difficult. So thank you for sharing your story, your insights. I know people on the call have appreciated it. If you have questions for Dawn Marie, please put them in the Q&A box, and I'll make sure we get to them. I know that there has been some back and forth in the Q&A around a different issue that's also quite difficult. People who are without status here and how we can support them. And maybe Ritika, I wonder if you could summarize some of that conversation that you've been having in the chat.
Yeah, absolutely. Thanks for raising that, Andrea, in the chat. So Andrea raised around people who are undocumented that might already be getting services through community health centers, or now actually I was mentioning that during COVID, we've actually seen, in response to some community advocacy, the province has put out a directive that actually all people, regardless of immigration status, can access healthcare services. So there are now even billing codes. So hopefully everybody on the call has seen those. So if you are seeing people who don't have OHIP, you now can bill those special billing codes. But the second piece really was around any of these financial services. I know that a number of advocacy groups have been trying to get a way for the different income benefits to be able to benefit people with precarious immigration status, but I'm not aware of any actual movement. The piece that I did mention is that sometimes if people have a humanitarian claim in process, they may be able to access Ontario Works if they're not working and not able to work, but I'm not aware of any specific benefits.
Thanks, Ritika. I want to turn it to our last two panelists, starting with Johnny. Johnny, I wonder if you could take a moment to share some of your own experiences. I mean, you work in a very different setting up in Kenora. And of course, as you mentioned, a big part of your work is providing care who are homeless, to people who are homeless, many of whom are struggling with mental health and addictions. Maybe you can tell us a little bit about your setting and how COVID has affected your patients and how you're supporting them.
Yeah, thank you, Tara. And I'd like to first off draw from what Ritika had mentioned about the flurry and panic that we all experienced, especially at the start and the first few weeks of COVID. it was a flurry of panic, which affected everybody across all spectrum of health, social care, and patients at the ground level as well. And that, I think, made it rather challenging to instantly, make good decisions, rational decisions about how we continue to provide equitable access to healthcare, especially when I have my hat on of providing care on the street. And so I've been really fortunate that we've had some really strong patient advocates and support, and this wonderful man next to me, Will, has been one of those really strong advocates for equitable access, really. And so for me, the key thing that we've really established during this time is understanding the co-partnership between patients and healthcare providers. Especially in a fairly resource-strapped, isolated location in Northwest Ontario, with significant social challenges which are disproportionately affected, especially in Indigenous groups and those with mental health and addictions challenges. And so I think part of dealing with that flurry and panic is also just trying to be realistic, which is, as Ritika also talked about, how can we continue to provide the same quality of care, appropriate healthcare services, especially trying to mitigate those health inequities and social inequities, whilst still having a busy family practice, as Bilal has mentioned, in the UK. And I know the landscape in British practice as well, so I've seen, I know where you're coming from, Bilal. It's a challenge, and I'd like to say a call to action from my point of view is, we'll step out of your office and do the work. But I know it's not as easy as that, because we're very busy, especially in resource deficient areas. So what I want to talk a little bit about is helping provide this, the appropriate family care, primary care, with co-partnership with patients. And actually, I want this to be more of a conversation between Will and I, rather than a sort of a 10-minute lecture between the two of us. And actually, you're about to hear my kids appear around the corner. I should have shut the door. But maybe I'll just ask Will to kind of talk a little bit about some of the challenges you've faced and some of the positive things that you've seen come out of this.
I think since the beginning of COVID, a big part of it is Dr. Greg coming to us, or to, we have a bit of a tent community here, where on the street, the outreach team will come right to us weekly. And that's a big part, because some of us don't have access to virtual, like to the internet or to devices to communicate, although Dr. Greg will communicate through Messenger or social media has been a big part. And without that, I don't think we'd be able to access care. It's been a little challenging to practice social distancing when accessing care, or Dr. Greg coming out, but we're managing. And I think, again, without the outreach team and without them coming to us, it would be next to impossible.
One of the big fears that I've had through this is an erosion of trust. Again, Ritika mentioned this, that we've worked hard on being able to build up trust in, and some populations, and I'm sure you'll agree, Will, do find that more of a difficult thing to attain with their healthcare providers. And it's the reasons why we see people not presenting to their primary care officers and to the emergency departments and so on. So we've been worried and really sort of trying to actively work on, well, how can we continue to maintain the level of trust and rapport that we've built up with our patients, but still adhering to the appropriate PPE and guidelines about social distancing. It's really difficult, and I can't say that has gone overly well. And I am sure that there will be some patients and populations here in Kenora, but also in the GTA, and everybody that's joining the call, that has found that relationships have been damaged as a consequence of all of the very strict measures that have had to be put in place for public health reasons. What would you say about trust, Will?
I think as some services have fallen off because of COVID, or some support groups aren't available, things we've come to rely on or had a relationship with, there's sometimes a sense of abandonment or, you know, a breach of trust. And that took a long time to get. And it's not going to be replaced quickly. And so it's important that some of those services remain or still reach us, because once that's gone, it's going to take a long time to rebuild that. And I know there's a sense of abandonment by certain people who are homeless or on the street when some of those services have fallen off. Luckily, the outreach team has remained, you know, solid, and that as much as possible that relationship's still there. But for a lot of services, it's not.
During the earlier stages, when we were planning for our isolation center setup, which we were able to successfully get here, we were having to use an interim solution of hotels for those who were unable to self-isolate in the light of possible COVID and positive COVID screening. And unfortunately, Kenora has not been hard hit, but you know that the potential is and was still there. Now, one thing that was difficult to navigate during that time was, I think there were certain providers and certain organizations that would come to expect that because patients are in reported isolation or in these hotel options with somewhat sustainable housing for a few days or weeks, that therefore that they would be able to give up or recover from their addictions or somehow change behaviors that have been part of their lives for such a long time. And that's just not the case. And so we were excited when the BC Centre for Substance Use had come out with one of their guidelines, which I'll share after this, about how do we look at a safe supply model and how can we continue to help those who otherwise would need access to a stable supply of their drugs or their medication, depending on how you look at it. And so that was something which helped to an extent to mitigate some of the expected kind of behaviors, as it were. But we couldn't expect those things to just change and people to just recover from addictions because all of a sudden they have housing for 3 days. I don't know if you'd want to comment on that, Will.
Yeah, that was a difficult time for us because when we were housed in hotels to isolate for a while, you know, certain things that were normal to us, going out to get or to use, was frowned on by the owners of the hotel or certain services here in the area. And it's not like Dr. Grech said, that a 25-year opiate addiction was going to be cured, or that part of our life was going to be put on hold because we were housed in a hotel for a few days. We were still going to have to maintain our addictions, and certain things were still going to have to be part of our lives. So that was a little difficult at times because it wasn't approved of by wherever we were housed at the time.
We're still in this, and we're still in this period of time that I think, with weather being slightly better and local agencies through some of the collective impact initiatives that we're trying to work with all of the different agencies, especially the police, we've been fortunate in a way that some have been able to find a sustainable housing solution, as it were, which is a tent city. And so really continuing to provide the outreach services and stepping out of the office and offering those equitable accesses without being able to use a virtual care model. We've been fortunate to do that, and I would encourage any listeners to try to do the same. But I recognize it's a significant time component. The ways in which we document these things on the EMR are challenging, and as has also been mentioned, the compensation for that through OHIP and so on is maybe not going to be as recognized. But I still encourage, especially because we will join this call, that is what we do. We step out of the office, we have patients as co-partners, and significantly in Kenora, and I don't know the GTA area and those who are joining from across Ontario, but keeping this rooted in culture as well. There's a significant amount of spiritual healing, and the emotional and spiritual aspects of one's healthcare have almost certainly taken some damage during this time as well. And so we've really tried to keep that as part of the work that we do. Easier said than done. I don't claim to have done this effectively, and there's been missteps, I'm sure, and that flurry and panic that we've really all experienced at the start, but all the way through. It's been a hard time, but I think we're learning, and so I appreciate the opportunity to kind of share some of that with you and listen for any comments that might come. Thanks.
Thank you, Johnny and Will. Provided a lot of insight, and I think one theme that I'm hearing come out from all of our speakers today is how difficult it is to provide virtual care to people who are socially marginalized, and that we do need to provide in-person care often, and figure out ways to adapt to lower the risk to ourselves and our patients, but still be there for them. And I think that was a theme that came out on some of the other calls we've had. So our community of practice focused on mental health and addiction. So certainly the note we left on as well, that mental health and addictions are suicidality is an acute reason for seeing someone in person, and you could be saving their life to do so. So just a great reminder to us. I think one question I'm going to put out to the group which was asked by one of our participants. And actually, sorry, before I do so, I just want to mention, I see a couple of hands raised, and I guess, unfortunately, with Zoom webinar, our participants can't speak. So if you do have a comment and would like to share it, I'd ask you to just type it into the Q&A. If it's a question, if it's a comment, you can put it into the chat, and I'll definitely highlight that to our panelists. But one question that came through early on was, what are things we should be doing right now proactively as we plan for ramping up care to better address social determinants of health? Because we know that primary care has been open, but the in-person services we've provided have had to be more limited. What should we be thinking about as we move to this next stage in the province? Ritika, it seems like you wanted to take a stab at that.
Yeah, I'm happy to speak to that a little bit, because I've been sort of moving in this direction, I'd say, in the last few weeks. So I have two settings that I work in. One is a family health team and the other is a shelter-based clinic. So very different in terms of the resources I have available. And I have noted really a substantial decrease in my ability to connect with people, as I've mentioned, for those who are most marginalized. So I've just started in the last few weeks taking a different approach when I'm able to connect with somebody, and essentially just really offering people to come in person with a very low barrier. So in the past, while we were kind of saying we'd really, if we can do it by phone, we'd really encourage doing the appointment by phone. Instead, my starting point now is, I'm here in the office, I'm happy to see you. If it would be easier for you to come in person, I'm very happy to see you. And a lot of people have taken me up on that, because they recognize, even if it's not like they have a wound that needs to be physically assessed, they find it much easier to connect with me in person, and they find it much easier to actually get into some of their more complex mental health issues and other issues if they're able to come in person. So that's just one thing.
Thanks. Anything else that other panelists wanted to weigh in on?
I can
Brian,
jump in.
I'm wondering, go ahead.
Really quickly. I've had a family doctor for a very long time who just recently retired. So trying to connect with somebody virtually has been challenging over this time. As Ritika just said, it's very hard to give, if it's a walk-in clinic or something, it's not in person, it's over the phone, a doctor's visit. So it's very hard to talk about what's actually going on. But I know that's what we have to do, and I know that's what we're moving to. I just wanted to point that out from a patient perspective, that it is challenging. So I guess, just patience and asking questions and listening. I found that when I was talking about my symptoms, for example, extreme stress, I wasn't asked what's stressing me, and those kind of things that we look for when we're in connection with somebody in person. But I just think that it is a strange phenomenon now, and we just have to do our best, I guess.
Thanks, Dawn Marie.
So Tara, I can yeah, I can weigh in. That's just on the we've addressed this a lot, just around how can you safely see people in person, and the PPE question, what's necessary and what's essential, and looking at what's the priority around in-person visits, and I know that we all make our own personal judgments, but in terms of safety, interacting with somebody from a 2-meter distance and wearing a surgical mask and hand hygiene and having that conversation in person from in that under those sorts of conditions with the basic PPE. We don't need a gown to see everybody. Are safe enough, and that though that physical, we talk about bringing people in who need a physical examination. I think one could say that the interview that gets the body language is a physical examination. So I think that's, though it's not actually touching someone, what you gain through the cadence of a conversation and facial expressions, albeit we get their eyes, and the way that it is just so much more effective to have a mental health conversation in person, and we are free to do that. There's nobody that is telling us we cannot do that, and I think we really do need to lower our thresholds for those in-person conversations with new patients, as you're mentioning, with patients we know a little less well, and with people who are struggling with their managing of COVID, but managing with life.
Mm-hmm. Brian, I wonder if you could put up our slides again. Actually, we could go to the OCFP PPE slide, because I think that was what Jennifer was referring to. So I think it's just a great reminder, a visual of some of the tips and the handout that people could go to, because this is about also having us see people safely. Not this one, Brian, just a little bit up earlier, the graphic with Jennifer on it. If you, yeah, perfect. Thanks, Brian. So I think this is the slide this is what you were talking about, Jennifer, and it's a great 2-page handout that the OCFP has developed that helps to really guide family doctors on what is needed to safely see people in person. Brian, if you take us back a few slides to the resource folder slide. I wanted to also give Rithika a chance to talk about this resource. I know people have been grateful for the resource, the Center for Effective Practice DFCM Upstream Lab Social Care Guidance document that we had just put up, and Rithika, you shared the link online in the chat, which is great. But this is also a different resource that I know you and colleagues put together, and maybe you could speak to it. And Brian, maybe you could actually go to the website.
Yeah, absolutely. And the credit for this goes entirely to Carnell Williams, who is a health promoter in our family health team. So she's been collating right from day one, this Google Drive, which is accessible to anybody who has the link. And I think if you scroll up in the chat, the link was put there as St. Michael's Hospital Marginalized Populations and COVID resource file. So it's, as you can see, it's really,
sorry,
really
organized. Zoom in a little bit, Brian, because it's a little hard to see. I don't know. Perfect. That's great.
Thanks. So, so it's great because it's really organized by different resources. One of the challenges that we've had, particularly in Toronto, is that there are so many agencies that have shut down during COVID or have different hours. But then there's also all these new things that have popped up. And we also shared something called takecare19.com, which is a website of mental health resources that's kind of come together during COVID. So if you go through this website, this Google Drive, it goes through specific resources around housing, around food, around income supplements, legal supports, etc., mental health supports, addiction supports that are available particularly during this time. So I really encourage people to take a look.
And then, Brian, there is a slide, Take Care 19, accessible and inclusive mental health resources. Maybe we can put that up because Ritika was just talking about that. Did you want to speak anything more about this specific resource, Ritika?
Yeah, so this looks like it started out as a Google document that was being shared with just resources around COVID-19. Again, new things have cropped up, and then they've turned it into a website, which is really nice. It's really easy to search, and you can search based on city as well. So there may be things that are, I think there's things that are outside of Toronto. There's also things that are outside of Ontario and Canada in here. There's also a number of virtual options. So I've referred a few people to kind of online CBT and different virtual options for care. So it's a great resource.
And I do want to draw people's attention if they're thinking about mental health and addiction support. We did have a great session on mental health on May 15th, and that session is archived on our website. And we have a long list of resources, including places where you can get free psychotherapy at this time in Ontario, so a psychotherapy that's covered. I know that there's also been some great chat going on. It sounds like, that some people are interested in maybe even customizing some of these tools, and people were particularly interested in the financial resources listed in the social care guidance. There have also been a number of shout outs on the chat to our patient partners and their sharing of their stories. So just wanted to particularly thank Dawn Marie and Will Lacey for doing that today. It's the first time we've had patient partners on our call, and I think it added a depth of perspective that we didn't have before. And I know many people on the chat really have appreciated that. So I don't see any other open questions at this time. I wonder if I just wanted to highlight that there are a couple of resources we highlighted last time that I'm just going to, they're not related to this specific topic, but I know it's on everyone's mind. So if we go to the end there, the guidance on reopening slide, Brian, just to let people know again about all of this great guidance that's out there. Again, this is archived on our site from the last community of practice that we had, so all the links are there, but certainly encourage you to check it out. The Center for Effective Practice website also has a number of other tools, and are also doing academic detailing. So for example, if you wanted to meet with someone one-on-one to go through something like the social care guidance, in many regions, the Center for Effective Practice is offering that service. So thanks. We'll go to the next slide, Brian. I just wanted to thank all of our panelists and attendees today for coming together. I think it was a wonderfully rich session. And as mentioned, we will compile all of the resources that were shared on the slides and the chat and in the Q&A, and have those on our website, and also we'll email them out to all of the attendees. We have been running these community practice sessions bi-weekly, and we send out an evaluation after the session, and really appreciate your feedback on that in terms of what topics you want to see, what we could be doing better. Did you enjoy having patient partners join us today? That was a new thing, so would love your feedback on all of that. On July, our next session won't actually be in 2 weeks, but because it's this summer, we'll be doing it on July 17th. So we'll go on a bit of a slower pace over the summer. So our next session is on July 17th. And at this time, we're planning to discuss chronic disease management, chronic care management during the time of COVID, something that I know we've all been thinking about. We have people who haven't come in for a long while. They have many conditions other than COVID that they're struggling with. How can we support them in a way that's safe? And of course, this is accredited, and so you'll get your main pro credits emailed to you about 2 weeks after the session. These are the two websites, our OCFP website and the COVID Community of Practice website, that you can check out for additional resources. So thank you everyone for joining in today, and stay safe.